Welcome to the week 4 of the Nursing Leadership and Management course. At the lecture for this week, we will discuss the topic of managing resources, which will entail management of information technology, management cost and budget, care delivery system, staffing and scheduling, and selecting, developing, and evaluating staff. Before we start the review the management of resources, let me go over the objectives of today's class. By the end of this class, you should be able to analyze the core components of informatics, data, information, and knowledge, discuss knowledge systems and their use for patient care, explore the issues of nursing with ethics and patient confidentiality information technology, describe the budget preparation process for healthcare organizations, define commonly used budgets for planning and management, differentiate the characteristics of 5 care delivery models used in healthcare, determine the role of the nurse manager and the staff nurse in each model, describe the implementation of a disease management program, explain several major factors that are escalating the cost of healthcare, and compare and contrast various reimbursement methods and their incentives to control cost. The first topic for this part of the lecture is discussing management information and technology. Informatics is a science that combines domain science, computer science, information science, and cognitive science. It is what allows us to advance the way in which we perform nursing care because it allows us to synthesize the latest information into our practices. Our focus today is on knowing the 5 key elements of evidence-based practice and then validating that we can identify the key types of technologies that affect our practice. Here are the 5 elements of evidence-based practice, as described by Mayer and Elliott. We're going to look at each in the next few slides. You ask the clinical questions, acquire evidence, appraise the evidence, apply the evidence, and then assess the outcomes. One way to remember how to ask the important clinical question is to use the PICO model. Here are the 4 elements of the model. Population relates to such factors as age, gender, ethnicity, disease group, and so forth. Intervention refers to the nursing action that should produce the best outcomes. Comparison refers to examining one approach against another. Outcome refers to the data, such as percentages of effective resolutions of the problem. PICO determines the nature of the question. When you find evidence about your question, you should then use these 3 filters or questions that the Oxford Center for Evidence-Based Medicine says are important to appraise the evidence. Applying the evidence varies among organizations. For example, in a hospital in which there is a real commitment to effective change at the bedside, nurses can discuss their findings and immediately test new approaches to problems they have encountered. In other situations, more complex processes throughout this organization, not just at the unit level, require formal proposals and widespread discussions prior to enacting the change. Leaders, managers, and followers all have roles in ensuring that we are practicing from an evidence-based. Leaders need to strategize how to obtain the necessary hardware so that staff can be effective in gaining the information needed. Managers need to focus on how staff can access the literature, whether by ensuring patient coverage or by advocating for unit-based hardware and access. Followers need to point out issues in patient care. support the managers in gaining necessary access, and making cases for patient safety as the driver behind evidence-based care. We're going to turn now to the types of technologies that affect our practice and that managers and leaders need to ensure are available. There are three major types of technologies which we need to concern ourselves. These are biomedical technologies, informational technologies, and knowledge technologies. There are four types of technologies in the biomedical category. Because you know these from your clinical experiences, I'm not going into details. Physiological devices include measurements of vital signs, pressures and blood levels. Diagnostic testing include MRI and PTE scans and diagnostic ECGs. Drug administration includes programmable pumps to control the rate at which medications are introduced into the body. The most common one is probably the insulin pump. Therapeutic devices include any of those at the bedside that assist in regulating fluid and air intake and output. Information technologies include the way in which data are handled. The electronic health record is one example. An organized retrievable storage system that allow many providers and insurers to know what an individual prior health background is and what is happening for that person right now. There are many ways in which this information is shared in a healthcare organization and throughout the system of healthcare. And the last type of technologies is the knowledge technology. These are, in a sense, an electronic process to reach decisions quickly. The rules for how data is to be entered into the system have to be clear, and all data points must be present for the computer to perform the decisions. This is an example from your text shows how to reach a decision about giving the maximum dose of pain medication. This is the way we make this decision on a regular basis. So it may seem strange to think through it in this manner. However, we know that nurses may miss the time frames or the allergy factors. In addition to assisting the non-expert to reach a decision quickly, these systems prevent missing of steps in the process, even for experienced nurse. In summary, technology can transform what we do in practice. Our commitment is to create the program that supports what we need to do and to use the data available to us. Our next topic for this part of the lecture is managing cost and budget. Real GDP is an important indicator to track because it provides the greatest and broadest sectoral details of any other series. Data reflecting income as well as expenditure flows. Sectoral coverage includes durable and non-durable goods, structures and services. Also, prices that data by sector are available for detailed subcommittees. The GDP or gross domestic product is the broadest measure of the health in the U.S. economy. Real GDP is the output of goods and services produced by labor and property located in the United States. Why we care about GDP? As the percentage of the GDP that is spent on health care rises, the more likely others that are external to healthcare will want to fix the situation. The GDP suggests that we must be engaged actively in helping to change the healthcare system. Health disparities. Do we get what we pay for? Health disparities based on gender, race, and socioeconomic status continue. The U.S. infant mortality is among the highest in the world. The U.S. life expectancy is the lowest than in many other developed countries. With these facts, it is clear that we are not receiving high value for the amount of money we spend on healthcare. Among the top factors increasing healthcare costs are price inflation, administrative inefficiency, unnecessary care, and pharmaceutical usages. Price inflation is caused by many factors, including the rate with which physicians' incomes rise, which is greater than the average earnings increases. Administrative insufficiencies are largely related to the number of clerical personnel it takes to process reimbursement from multiple payers. The U.S. hospitals spend an average of 20% of their budget on billing administration. Unnecessary care includes using the hospital emergency room when a clinic service would suffice, as well as ineffective medical procedures, some of which were selected because of public consumer pressures. Pharmaceutical usage has increased, and as pharmaceutical companies have marketed their products directly to consumers, they are asking for the latest medications and thus pushing costs up. Part D of Medicare further complicates the scenario due to confusion and complex plans for coverage of medications. The four key resources for healthcare financing are 36% or government, 41% private insurance, 19% individual, and 4% others. As you can see, the government, primarily through Medicare and Medicaid programs, pays the most as a single source. Private insurance companies, while paying more of the overall percentage, are composed of numerous individual businesses. Almost 75% of the government spending is at the federal level. Because the government pays such a large percentage, you can see how the Center for Medicare and Medicaid greatly influences what happens in health care. The primary payer of health insurance is Medicare. Part A covers organizational services such as hospitals and home health. Part B, which is optional, provides for healthcare provider payments, medical equipment, and diagnostic tests. 2006, Part D, the drug benefit program, went into effect. Medicaid is a state-level program which costs shared between the state and the federal government. The funding from the federal level is dependent on the per capita income of the state. In addition to covering the medically indigent, which are who the public usually thinks of as being the targets of this program, Medicaid also covers persons with disabilities. There are four types of payment methods. Charges are the cost of providing a service plus a markup for profit. The usual and customary is a term that means third-party payers have surveyed providers in the area to establish what the payer will pay. So, a hospital could tack on a markup and not necessarily receive it because it far exceeds the usual and customary charge. The cost-based reimbursement calculates all allowable costs and then uses that as the basis for payment. Each payer determines what the allowable costs are. Both of these approaches have been largely replaced by payer fee schedules. Flat rate reimbursement is based on the payer deciding in advance what the payment will be. If the costs are greater, the provider absorbs the cost. If the costs are less, the provider benefits. Capitated payments are based on the provision of specified services to an individual over a set of periods, such as 1 year. The capitation or per head person fee is set, and the desired is to provide needed care at the lowest cost possible while meeting standards for care. Managed care is a health plan that brings together the delivery and finance function into one entity. The goal is to decrease unnecessary services, thereby cost. Knowing how each affects the other and knowing how to talk in terms of value to care are skills that nurses need to know in order to be financially savvy. So, what does this mean for nurses? Well, we must think of our practice within a context of organizational viability. We must be able to do financial thinking. We must think of our service in terms of value added. We must exercise cost-conscious nursing care practice. We must focus on patient needs, not provider needs, organizational need practice. We must provide evidence-based practice, and we must incorporate and evaluate new technologies. We also must use research to better our practice. Our next topic for this part of the lecture today is to discuss care delivery strategies. Nursing care delivery model can be defined this way. It is a strategy used to provide care to patients in a variety of settings. Several considerations must be made when selecting a model. For example, you might want to provide primary nursing, but the availability of staff and economics of it are prohibitive. Each of these factors influence the decisions about delivering care. There are 5 methods or models for providing care. Note these for now. We will return to them later. There are case methods, functional nursing, team nursing, primary nursing, and case management. There are other strategies too you may hear about. Those are disease management programs, patient-focused care, and differentiated practice. Several factors influence the way in which care is considered. The magnet recognition program of the American Nurse Credential Center does not dictate a particular approach. Rather, it expects that the staff and administrators can describe why whichever approach they use is the best for their situation. The synergy model, developed by the American Association of Critical Care Nurses, is a comprehensive approach to care. It starts with a philosophical approach to care that drives the way the care is delivered. A third consideration is the clinical nurse leader, which was developed by the American Association of Colleges of Nursing. This role is designed to help staff solve problems and increase the quality of care delivered on a clinical unit. Let's look at the main models. The first is the case method. From the information you know about the case method, please think about these 2 questions. What are the advantages of the case method and what are the disadvantages? Now, let's look at the role of the nurse manager in the case method. Role of nurse manager to assess patient needs to determine level of care, whether it's an RN level care or RN supervised level care, or hiring and management of appropriate staff to provide total care in a cost-effective management. The next model here is functional nursing. It has several advantages and disadvantages. Some of the advantages is it's efficient, assistant personnel can learn tasks, and it is cost-effective. Disadvantages might provide fragmented care, patient family needs might be overlooked, might lapse in communication, quality of care may be compromised, and staff nurses or professional nurses might have some frustration with this type of care delivery model. Functional nursing model, based on what you know, think about these questions. What is the role of the nurse manager in this model of care, and how does the staff nurse function in such a model? Team nursing, or a modification of it, is prevalent in many care settings. Team nursing has some distinct advantages. It also has some disadvantages. Some of its advantages are cost-effective. Decisions are made at the grassroots with involvement of staff, and it improves patient satisfaction. Some of the disadvantages is it needs skills of knowledge. A knowledgeable team leader needs adequate staff mix with a skill mix, has potential for fragmentation of care, and a few work settings implement team nursing as originally designated. Why do you think is the last statement about the disadvantage is true? Think about that. Effective teams have clearly integrated interface among these roles. The team leader, charge nurse, and nurse manager role. Because the focus is on the team, coordination takes on great significance in such a delivery method. Primary nursing is explained in this figure. It too has specific advantages and disadvantages. Some advantages are this type of model provides autonomy, motivation, holistic care, increased communication with health team, increased patient rapport, and works with professional staff. Some of the disadvantages for using this delivery model is costly for agency. RN may not want to be a 24-hour responsible, and RN may lack experience and autonomy. There are two primary hybrid delivery models of care exist. They are the partnership model and the patient-focused care. Nursing case management can be defined as the process of providing comprehensive care for those with complex health care programs. It results in improving outcomes, decreasing length of stay, interface with multiple disciplines, and care provided across the continuum. What populations of patients are best served by the utilization of the nursing case manager model? Well, some examples are cardiac patients, such as patients with heart failure, high-risk perinatal patients, particularly those that are on home monitoring, pediatric patients, especially those with chronic illnesses such as cystic fibrosis, type 1 diabetes, and AIDS. In a case management, there will be a manager leader of the nurse case manager. This individual will manage and lead the quality improvement process, making sure that the paths and maps are current and relevant with the care practices and reimbursement methods. It provides oversight with case managers to be sure case loads are appropriate and effectively managed. Interface with other disciplines to clarify the role of the nurse case manager, and creates opportunities for staff development, and might include individuals from other disciplines. Your text discusses critical pathways and care maps. Here are some questions to think about and consider. How are critical pathways and maps developed? What are the difference between the two, and why these tools used by a nurse case manager? Disease management is often found in the management of a group of clients with a comparable disease. It's a model of care that coordinates care interventions for those with chronic illnesses. In such a delivery model, there are frequent follow-ups, there's an emphasis on self-care, and utilize best practice for clients with chronic conditions. The other major hybrids is differentiated practice. What did the text suggests as the primary differences among these roles. The nurse leader or manager performs several roles in differentiated practice situations. Those are role model, collaborator, coach, teacher, facilitator. Can you guess what leadership theory relates to these role components? Have you thought about transformational leadership theory? If you are interested in being more on the cutting edge of care delivery issues, I suggest you read about one or more of these three topics: magnet recognition, synergy model, the clinical nurse leader. In conclusion, the role of the staff nurse is critical in each model that we discuss. Please think about these questions and try to answer them. What do you think it would be like to be a staff nurse in each of these models? Which model would be the best fit for you? Why? Which model is the least appealing to you, and why? Remember that many organizations modify what they do, but the roots of their approach are typically found in one of the models discussed in this presentation. Thank you.